everyone. Welcome back to Dr. MS Corpus. If you're new here, hit that subscribe button and turn on notifications because we are starting an amazing journey together. Today, we are diving into something we all experience but rarely understand: pain. Now, before we start, I have a few clinical situations for you to think about. Have you ever wondered why a paper cut hurts so sharp at first but then turns into a dull ache? Ever seen a case in your emergencies where a 34-year-old construction worker, after a nail gun misfires with the nail embedding in his left hand, still he's calm, joking with the staff and rates his pain 3 by 10, whereas in the next bay, a 28-year-old office worker with a minor paper cut, visibly distressed, rating her pain to be 7 on 10 and requesting strong analgesia. Is the tissue injury same? Not even close. Yet her suffering is clearly greater. How do we explain this? What happens when you touch a hot pan? You brush against a scorching pan before your brain even forms the thought that it's hot, your hand snaps back. A beat later, the burn first sets in as sharp, intense, then slowly deepening into a lingering ache. How did your body act fast than your conscious mind? Why does pain arrive in two distinct ways? Drop your answers in the comment section. This is part 1 of your pain physiology series, and by the end of this video you'll understand exactly what's happening in your nervous system when you feel pain. Let's get started. What are the learning objectives for today? First, we'll understand the difference between pain and nociception. We'll identify the type of nociceptors and pain fibers. We'll explain how pain signals begin and travel to the CNS. And finally, we'll look at some real clinical examples you will see in your practice. Sounds good? Let's go. Before that, a few more clinical vignettes, which tell us that pain doesn't always mean damage and damage doesn't always cause pain. We have seen soldiers who have walked off battlefields unaware of serious wounds. Patients with severe arthritis, visible on x-rays but sometimes report no discomfort at all. Others suffering debilitating pains, but there is no detectable injury. What does this all say? That pain is far stranger and far more sophisticated than most people realize. So what is pain? Pain is a protective biological mechanism. Think of it like your body's alarm system. When something threatens to damage your tissue, whether it's heat, a sharp object, or chemicals, your body needs to know about it immediately. Now, here's something important that confuses a lot of students. Pain and nociception are not the same thing. Let me break this down for you. Nociception is an objective process. It's your nervous system detecting harmful stimuli. Think of it like a sensor going off. Whereas pain is a subjective experience. It's what you actually feel, colored by your emotions, past experiences, and even your current mood. How does the body detect pain? Alright, it all starts with specialized receptors called nociceptors. These are the free nerve endings. You'll find them everywhere in your skin, in your muscles, joints, and internal organs. Now, nociceptors respond to 3 main types of stimuli. Let me walk you through each one. Number 1, the mechanical stimuli. Think cuts, pinches, pressure, any kind of trauma. When tissue gets stretched or damaged mechanically, the nociceptors fire. Thermal stimuli. This is extreme heat. Anything above 45 degrees Celsius or extreme cold. Your hand on a stove, that's thermal nociception. And number 3 are the chemical stimuli. This is where it gets interesting, okay? When tissue are damaged, they release chemicals like histamine, prostaglandins, and bradykinin. These are inflammatory mediators and they activate nociceptors. Here's a clinical pearl for you. Prostaglandins don't just activate nociceptors, they sensitize them. That is, they lower the activation threshold. Let me give you a real world example. Ever had a sunburn? Even the softest touch of your shirt feels painful after a sunburn, right? That's because prostaglandins from the inflammatory response have made your nociceptors hypersensitive. This is called hyperalgesia, increased pain from a normally painful stimuli. Quick question for you. What drug would you think would help with this? Hint. And I have a hint also. These drugs block prostaglandin synthesis. Drop your answers in the comment box. Now here's something you have probably experienced but never knew the reason for it. The double pain. Have you ever stubbed your toe and felt two waves of pain? First a sharp, then a deeper ache. That's just not random, it's physiology. When you get injured, the pain signals travel to your spinal cord through two types of nerve fibers. First up, A delta fibers. These are thinly myelinated, conduct fast signals about 5 to 30 meters per second. They give you that sharp, localized first pain. And second are the C fibers, which are unmyelinated, conduct signals slowly about 0.5 to 2 meters per second and give you that dull, aching second pain. Think about getting a needle prick. Ouch! That immediate sharp sensation? A delta fibers. Then a few seconds later, the burning, throbbing feeling comes. C fibers. This is why we call it the double pain sensation or first and second pain. Understanding this is crucial because different pain medications can target these different fiber types. More on that in future videos. Alright, let's talk about something that might sound complicated but is actually super cool. The TRP receptors. TRP stands for transient receptor potential. Don't worry about memorizing that at all. What you need to know is, these are special ion channels on nociceptors that respond to specific triggers. Let me give you three most important ones. The TRPV1. This responds to heat above 43 degrees Celsius and capsaicin. That's the chemical in chili peppers. Then the TRPA1, the chemical irritant receptor. This one responds to irritating chemicals and is involved in conditions like asthma and bronchospasm. When you smell something harsh and your airways react right, the TRPA1. Then the TRPM8, the cool receptor. This responds to cooling agents like menthol. Ever used a cooling gel or an ice pack? It felt soothing, right? That's TRPM8 doing its thing. Then a clinical application. Capsaicin pain patches. When you apply capsaicin repeatedly, it overloads and desensitizes the TRPV1 receptors. That is why capsaicin patches help in chronic neuropathic pain. Here is a high-yield takeaway point. The TRPV1 desensitization equals reduced chronic neuropathic pain. Write that down if you are studying for your exams. Then a few clinical correlations. Let's bring all this together with some clinical scenarios you'll actually see. Remember that question from the beginning? Sharp pain immediately, the paper cut. Sharp pain immediately, A delta fibers. Then prolonged dull ache, C fibers. And now you know why. Then other one. A patient with post-herpetic neuralgia gets capsaicin patches. Initially painful, but over time, relief. Why? TRPV1 receptor overload leads to desensitization. And another case. A patient with arthritis feels pain even with a light touch. Why? Inflammatory mediators like prostaglandins have sensitized the nociceptors. Treatment? NSAIDs are used to block. prostaglandin synthesis. See how it all connects. This isn't just theory. This is the way you'll apply in a real patient care. Then the pain signal pathway. So we have spoken about all the fibers, the receptors, the double pain sensation, pain as a subjective feeling, that's all in your mind. Nociception is actually the process, everything. But how does this pathway signaling happens? Initially, any stimuli like a thermal stimulus, mechanical or a chemical stimulus gets sensed by the nociceptors, that is the free nerve endings or the receptors or the ion channels like the TRPV1 and all, then gets transduced into the nerve fibers. The two types of nerve fibers we have spoken, A delta and C, which carry the pain, gets conducted through to the spinal cord, and through a reflex arc immediately there will be a withdrawal reflex. The immediate removing of hand when you touch a hot scorching pan is a reflex arc which happens because of spinal reflexes. But yet that is not the end of the story. The spinal cord transmits information to the thalamus, which is the relay station. More specifically, the ventroposterolateral nucleus of thalamus is responsible for pain, and then it is processed in the cerebral cortex. What all gets processed there? From where your pain has come, what should be your emotional response be to it, and the emotion and all are connected through other systems and then the pain is perceived. And this comes down through the descending analgesic pathways. They undergo some pain modulations. These modulations can be amplified or inhibited through your past experiences, through your current mood, and also the brain. So if you make out a timeline of it, reflex would be like within 50 milliseconds. Then you get the first pain in 100 milliseconds, second pain at 1000 milliseconds. This is a rough estimate of the timeline. Clear? Let's recap the key points. 1. Pain is protective. It's your body's alarm system. Pain doesn't mean nociception. One is objective detection, other is subjective experience. Nociceptors detect mechanical, thermal and chemical stimuli. A delta fibers give sharp first pain, C fibers give a slow dull pain, and that's double pain. TRP receptors like TRPV1 are crucial targets for pain management. NSAIDs work by reducing sensitization by blocking the prostaglandin synthesis. Got all that? Great! Amazing work making it through part 1. You now understand the foundation of pain physiology. But here's the thing, we have only just begun. In part 2, we are diving into pain pathways through the spinal cord in detail, central sensitization, the wind-up phenomenon, and why chronic pain is so different from the acute pain. Before you go, I need your help with something. What do you want visualized in the next video? The spinothalamic pathway or the sensitization mechanisms? Give your comments. And here's your homework. Try to identify the double pain sensation in the next time you experience a minor pain. Notice that first sharp feeling and then the dull ache. Don't forget to hit that like button if this helped you. Subscribe and turn on notifications for part 2. Check out the practice quiz linked in the description questions. And any questions? Drop them in the comments or email me at drmscorpus@gmail.com. Thank you so much for learning with me today. Until next time, keep learning, stay curious, and I'll see you in part 2. Take care.